Hey, what's up everybody? This is Larry with Critical Care Academy. Today we're going to be talking about transvenous pacemakers. We're going to be talking about what the heck is a transvenous pacemaker, what it does, how it works, and we're going to compare some other therapies to it and even do a little troubleshooting at the end. So let's get into the action. Hey guys, welcome back to the channel. As you heard earlier, we're going to be talking about transvenous pacing today. So for those who have never heard of it, transvenous pacemakers, also called TVPs for short. So we're going to be saying a lot with TVP today. It just kind of helps shorten things up. Other modalities that are kind of in the same field, but maybe we're not going to talk about as much in depth, are going to be transcutaneous pacing, which a lot of people have seen before. They're the stick-on pads, so they may use these with a Zoll in an emergency. You can have the pads on the front and the back, or you can have them diagonally across the front of the chest to the sides. We're going to be talking just a little bit about epicardial pacers. They're the same principle as the transvenous as far as the usage of the box and how they work. They're just a little bit different in the attachment forms as far as how the leads go in. And then last but not least, there's also permanent pacemakers, which I'm sure most people have known somebody or has a family member or they've heard it in the community talking about permanent pacemakers. So next up, let's kind of talk about the indications as why we would have this pacemaker. So patients with symptomatic bradycardia, they've got junctional rhythms, idioventricular rhythms. They can have heart blocks, whether it be second or third degree. Any of these patients are capable of having a transvenous pacer. So a lot of times the question comes up as to, well, why would I want a transvenous pacemaker when I can just slap some pads on and use the Zoll right then and there? So one of the biggest differences in that is going to be the fact that, for one, it's very uncomfortable to be shocked by a pad over and over and over. Think about 60, 70, 80 times per minute you're getting this kick in the chest. So for the patient's sake, not comfortable at all. And two, this is really just a short-term solution when you're talking about transcutaneous pacing. Is it works great for the moment, but it is not a long-term solution. So that's when you say, well, why don't we do transvenous pacing? They take them down to the lab and we'll insert a wire, and then they can have a transvenous pacer for, several days until we get a plan together as to what we're going to do. So the biggest portion to this is, how do we determine which patients get them and which patients don't? Well, it's all about symptomatic. So if the patient is symptomatic from their slow rate, then they're probably going to need one. If they're not symptomatic and they seem to be doing okay, then we can monitor them, and if we need be later on, we can certainly always put one in. But that's your biggest determination when it comes to how do you determine which patients with a slow rate get a TVP and which ones do not. It's all in the symptomatic portion. So, causes to these things can be anything from medications, whether it be beta blocker overdoses. You can have ODs on street drugs. These can be ischemic changes, post-arrest patients, atherosclerotic patients. There's a wide variety of why we start seeing these, but essentially, there's a degeneration possibly in the conduction system. But even if not a degeneration, there's an interruption in the conduction system somewhere that we need to address. And this is a perfect solution. We can do these to these patients, and then they can still move around if they need be. They can still function a little bit until we get a permanent solution. So let's get into a little bit more in depth about the TVP. Also, we want to talk about, there are some side effects to putting in a TVP. Sometimes it depends on the patient, but sometimes your patients with more ischemic hearts, Sometimes the irritation of putting the wire in can actually cause more arrhythmias than the original problem that you had. Like I said, that's patient dependent sometimes, but that is also a risk. Also, pericardial tamponade is one. Risk of non-cardiac bleeding, because essentially we are putting a line in somebody, and also the possibility of a pneumothorax as well. When we talk about pacemakers in general, all pacemakers have a setting as to what they're doing, what they're sensing, where they're pacing, and they're all coded very similar. In this chart, you can see there's a variety of different ways that you can set one up. Most commonly on the one that we're going to look at today is going to be VVI, because they're sensing the ventricle, pacing the ventricle, and inhibited by their intrinsic rhythm as well. But just so you could see, there's several different ways that you could set this up. All right, so let's talk about how we get from point A to point B with a patient that comes in, and how exactly do we get to the point of getting a transvenous pacer. So let's say you have a patient that comes in with a third-degree heart block, is extremely symptomatic, blood pressure is in the toilet, and this patient is wavering in and out of consciousness, and we need to do something right now. So is a TVP a right now solution? Not really. So what we need to do is we're going to need to transcutaneously pace the patient. Depending on the rhythm, the underlying rhythm that they have, we can try certain medications to kind of pick that rate up a little bit. But if the patient's that symptomatic, we need to slap the pads on and we need to start pacing them off of a Zol. So this will bridge us over until we can get the patient to the cath lab. And that's where we're going to put in our TVP. So most commonly, once we get to the lab, the insertion site, most preferable is going to be a right IJ. They can do subclavian, but with anything subclavian, that comes with more risks. So, ideally, we're going to see an IJ insertion site. So your physician's going to put in a sheath or an introducer, vice versa. It depends on your facility what you have called what, but either way, the same principle. We're going to put in something that we can feed a wire through. And so once we get our sheath or introducer into place, then the physician can start running a wire down in. So what our ideal landing place for this is going to be a right ventricle down towards the apex. And once we set that wire down in the right apex, there is a balloon tip on the end of it. So you're going to inflate the tip, and it's going to be about the size of a pea, probably a little bit bigger than that. But, essentially we have the balloon on there, so if it bounces around at all, it kind of provides a safe environment for the wire tip itself, so it's not just in there jabbing around at every single thing there is. So what we want to make sure of is that, for one, placement is optimal. Now, can this change as the patient gets upstairs and moves and turns and rolls? Yes, it can, but that's where it's going to be important to know how to troubleshoot issues with the TVP, which we're going to talk about some. So as that wire comes back out of the patient, it's going to come up to a set of leads. So these two are basically just a single prong leads, and the prongs will plug into another cable that has more than likely a screw-in tightener on the top. So you'll have your pins into the cable, and then from there the cable plugs straight into the box. Some people will call that a pulse generator box. Some people will call it just a pacer box. It depends on where you're at and what you're used to. But essentially your box is going to control your lead. So each box is a little different. All the manufacturers are a little bit different, but in a sense, you're going to have the basic functionalities. So let's look at a box and look at the functionalities of what you're able to see and control with each box. All right, so on this box that we're going to look at today, this is a Medtronic box. And I'm looking at this box because I think for learning, I think this is probably one of the most simplistic boxes that I've seen to date. Everything is just right there in front of you. The dials are easy to denote which is up, down. It all sounds kind of silly, but when you're in the moment, simplistic is what you want. Problems with TVPs, they arise quickly and they give you virtually zero time to fix them sometimes. So the easier the better when you're looking at troubleshooting a TVP. So on this box, you're going to notice that up top, you have a rate section, and there's a knob to adjust it to set your rate at whatever the provider has ordered for you. And then below that, you're going to have an output. So this is going to be, the thought about this is the energy that the machine puts out to the patient. And you'll see that it is measured in MAs. And then underneath that is your sensitivity. This is also measured in millivolts. Easy to get the two confused. This is something that you'll just kind of have to hammer into your brain. Output is milliamps, sensitivity millivolts. So your sensitivity is what the machine uses to basically read what your intrinsic rhythm or your underlying rhythm is for the patient. So when you go to troubleshoot, you're going to have to differentiate between, is this an output problem or is this a sensitivity problem, which we're going to talk about a little bit more here shortly. So also at the top, you'll see that there's also a pace and a sense light per se at the top. So when this is connected to a patient and it's working, every time the box is sensing something of the patient's rhythm, it will light that light. If it's pacing, it will pace and light that light up. So it will tell you essentially, if you just look at the box, it will tell you exactly what it's doing. Your monitor should be able to denote a pacer spike from an intrinsic rhythm, and you should be able to see it both ways, but it's nice to be able to glance at the box and see exactly what it's doing. Now there's other functionalities of other boxes as well. So they all have the functionality of asynchronous pacing, which is basically a blind pacing. It's going to pace regardless of what is happening. With this one, it is a function that when you turn the dial all the way down to nothing, essentially it will asynchronous pace, and it will let you know. Other boxes, they have different styles of switches to switch back and forth between them. But I thought this box would be a good one to look at since it's pretty straightforward and we're all kind of learning here together. So now let's get into our next subject. So when we look at this box, the first dial that you're going to see on the top is going to be the rate dial. So this dial is what you're going to set for your patient's needs. This could be anywhere from 60, 70, 80 beats per minute, or even less if we're just using it for a backup pacer if the patient still has an intrinsic rhythm. The next dial that you're going to see is the output dial in the middle. So this dial, think of it, is how much energy does it take to get from the catheter tip over to the muscle of the heart to create a contraction, or in another term you'll hear is capture of the heart. So this is measured in MAs, not to be confused with the MVs in the next one. So the last dial that you're going to see is the sense dial, or sensitivity as some people will call it. So this one is going to be a measure of what does the pacemaker actually see for the patient. This is going to make a difference in how well your pacemaker actually does for the patient. So we need to make sure that we see that it's in millivolts versus milliamps. So these two can be confusing, but we're going to look at them a little bit more in depth here. All right, let's break this down a little bit further now. Talking about capture. If you look in image 1, you can clearly see you have a pacer spike followed by a complex. This is gaining capture. This is what we're looking for. So image 2 now, you see pacer spikes, but you see no complexes anymore. So that's a failure to capture. So that is not what we want to see. This is likely because there is too little energy to cross the threshold. So in image 3 now, you're going to see a mixture of both. So this is an intermittent failure to capture. So this is something we may need to make an adjustment on at some point in time. Maybe it's moved over time. So next, how do we fix the capture problem? Well, for the most part, it's pretty easy. We're going to turn up our MAs until we get enough energy to capture again. There's always going to be some outliers that it's moved and you can't have enough energy to cross the threshold anymore, and those are the patients that need it repositioned. But as you can see in the picture, it's just like Darth Vader. It's not doing enough to get the job done. So a couple closing thoughts on capture. People always ask, why is it so much different from a ZOL when you're transcutaneously pacing and the amount of energy that you use versus a TVP? Think about the amount of mass it takes to go from the outside of the chest wall with a sticker all the way down into the heart versus something that sits right up beside of it. It's just a lot less gap to cover. And then why do we still see intermittent failures when we're making adjustments to our TVPs? Well, it could be patient positioning, it could be line was pulled on, there could be slack in the line. So these are the patients we're probably going to end up having to take back to the lab at some point in time and have it adjusted, or adjusted at the bedside, either one. All right, hopping straight over to sensing now. This is a little bit more difficult, I feel like, or at least it was for me when I was coming up. But the way I think about sensing is if you were standing in front of a wall and I told you to look over on the other side and tell me what you saw. If it's a really tall wall, then you can't see anything on the other side. Same as your pacer box. But if the wall's low, let's say it's only a foot tall, well, you can see a lot on the other side. So we're going to take a look at some examples of sensing with a wall to see if it can make sense to you like it did to me. Alright, so here's our two examples. So look at example 1. You've got this big tall brick wall and you can't see anything. There's a rhythm behind it, but you can't see a single thing because your amplitude or your millivolts are turned way up. So now your wall is really tall. So you can see in the transparent image underneath of it, there is a rhythm underneath, but you just can't see it because the wall is too tall. So we call this being too sensitive because the sensitivity is turned up. So look at number 2 beside of it. So now we have a lower millivolts and you can see multiple pieces of a rhythm. You can see a lot. And this is actually one that's turned down too low because ideally in somebody that's got a pacer that's in the ventricle, you only want to see a R wave. You don't want to see P waves, T waves, because those are all taken into account as to what the pacer sees. And that's what it thinks is a rhythm. So you only want a certain amount, which is the R wave. So looking at the last slide now, this is a correct picture of what we would be looking for. So if we're going to be thinking about our wall with our ventricle pacing device, we only want to see a R wave because that's what the pacer is going to recognize as an intrinsic rhythm. So we don't want to see a P wave, we don't want to see a T wave. If we start seeing those things, it's going to start thinking that you have more intrinsic rhythm than what you actually do. If you have a R wave and then it sees a T wave, it thinks both of those are complexes and they're not. So it's not going to pace appropriately. Just like as if it didn't see anything in the first set of slides, it's not going to pace appropriately either because now you're going to be pacing over top of your intrinsic because it doesn't see it. It doesn't even know it exists. So there's a lot of things to take into account when you start troubleshooting, but we're going to take a look at a few slides and hopefully it'll help clear things up a little bit as to what to look for and how to troubleshoot them. So look at this strip right here. What do you notice about it? What stands out to you? Well, if you said failure to capture, you would be correct. Notice that there are spikes, but there are no complexes following, meaning that there was a failed capture. So what are we going to do to fix it? You got it. You're going to turn up your MAs or turn up your output until you get capture. Alright, on the next slide, tell me what you see. Pay close attention to your complexes and your spikes along the way. So this is what we're going to call undersensing. This leads to overpacing. So it's not really seeing anything, and if you'll notice the spikes on the bottom, they have a rate of about 66, and then the top, the intrinsic, has a rate in the mid 80s. So what are we going to do to fix this problem? Well, what we're going to do is we're going to turn our millivolts down. That way, think of it as bringing your wall down so you can actually see around it again. Before it was too tall, you could see nothing, so it would just pace constantly. So as you bring the millivolts down, you should start to see a R wave again and pace correctly. Alright, in this strip, pay close attention to the gap. Think about what would give you that gap. Alright, so this one is called oversensing. So now it's seeing too much, whether that be a P wave or a T wave, it's interpreting it as an R wave. So therefore it thinks, oh, well, I don't really have to pace right now, so I'm just going to let it continue to be on its own. Alright, so the fix here is we're going to turn up our millivolts. We're going to bring our wall up. We want it to see less Otherwise, it's going to be underpaced and probably going to be symptomatic for the patient. So the last couple of tidbits that came to mind, R-on-T phenomenon when talking about pacing. Anytime you get a pacing spike that lands out in the T wave, you're always at risk for this, and this is something that will be lethal to the patient and can send them into torsades if not adjusted correctly. And then, so another one, speeding up the rhythm. So if you have a patient that has a lot of arrhythmias, sometimes speeding up your pacer rate can alleviate those arrhythmias, not quite giving it enough time to have the arrhythmias. These should be provider dependent and they should be involved in that decision making. And then the last one, failure to capture, a good failure. So this is also along the lines with the torsades and the R-on-T. So a lot of times you can have pacer spikes in the T wave and it does nothing. That's because this is what they call an expected loss of capture, and this is because it's in a refractory period in that T wave. All right, I hope everybody learned something today. I hope that you kind of took what I struggled with as a new nurse coming in and things that I learned along the way with troubleshooting especially. I hope this was helpful to you. I really do appreciate you coming and checking out the channel, and I hope to see you next time. Hey, had it going too. In depth, but there's going to be a way to sit. Scene 2.